My name is Andrea Pollaninjo, and I'm the Dean of the School of Public Policy here at UC Riverside. I'm delighted to welcome all of you to today's special online panel discussion on COVID impacts, responses, and recommendations. I'll be serving as a moderator for today's panel, and the best moderator is one who tries to stay to be as little visible as possible, and I'll try to do that. Before we start, I want to acknowledge the very important contribution of someone who is actually not on this panel, but she's sort of someone who started the whole idea for this panel session and went around and recruited all of the panelists for it. And she's been working hard at it for several months and then came to us in public policy to sponsor it, which of course we did very gladly. And that person is Professor Dana Burns. I think she is in the audience, but she's not on the panel as I mentioned her here. Dana is he's an associate professor at UCR and director of the Research Ethics Education Program of the Graduate Division. So coming to today's event, the first half of this event brought to you by the UCR School of Public Policy will be a conversation with the experts you see here on the panel, and they come from different UC campuses. And we will be exploring how COVID-19 has exposed and in many cases reinforced various issues of inequity, access, and disparities across many sectors of society, be they health, education, labor, and how it has also eroded trust in public institutions. And we have only haltingly begun to grapple with these realities, unfortunately. This panel will examine areas in which COVID or the response to COVID is having a significant impact and offer some recommendations for moving forward. Then we will time at the end of the event to Q&A from the audience. And I would like this to be as participatory as possible, so we will try to keep our comments from the panel side to a minimum. Audience members, if you have any questions you would like to post during the Q&A session, please do not send them via chat, but instead please use the Q&A feature, which you can find at the bottom of your screen. This is a webinar, not quite a Zoom seminar, so it's a little different. You can submit your questions anytime throughout the event via the Q&A feature. You don't have to wait until the end of the presentations to do that. So I would like to next move to introduce our distinguished panelists, starting first with Dr. Richard Carpiano, who is Professor of Public Policy and Sociology here at UCR. Dr. Carpiano is a medical sociologist and population health scientist who studies how social factors such as socioeconomic status, race, ethnicity, social connections, and community conditions contribute to the physical and mental health of adults and children. His research focuses on an extensive range of health issues and populations, spanning the life course and US and international contexts. He's been in the news quite a bit lately because everyone has been interviewing him about his work on vaccination take-up. Next, we have Dr. Edward Flores, who is a sociologist at UC Merced, who studies civic religion, immigration, race, and gender. Dr. Flores' research has included God's Gangs, winner of a major sociological book award, as well as several articles in leading journals, including Social Problems, Journal for the Scientific Study of Religion, and Ethnic and Racial Studies. Next, we have Dr. Joseph Kahn, who is the Ted and Joe Dutton Presidential Professor for Education Policy and Politics and co-director of the Civic Engagement Research Group at UCR. Dr. Kahn's research and writing focuses on the influence of school practices and new media on youth, civic, and political development. Then we have Dr. Francisco Pedraza, who is a political scientist here at UCR with appointments in the School of Public Policy as well as the Department of Political Science. Research draws on sociological, psychological, and policy processes, theoretical frameworks to better understand individual level policy preferences, electoral candidate preferences, political knowledge, and other political orientations like trust in government. We then have Dr. Whitney Laster Purtle, forgive me if I mispronounce your name, Whitney, who is an assistant professor of sociology, associate faculty in critical race and ethnic studies, and affiliated faculty in public health at UC Merced. Dr. Purtle is a sociologist with interdisciplinary expertise in race and nation, racial identity constructions, racial ethnic disparities in health, Black feminist sociology and praxis, and mixed methodologies. Her research primarily explores the formation of racial hierarchies and their impact on lived experiences, well-being, and identities of individuals. And last but not least, we have Dr. Andrea Pollaninjo, who is a Chancellor's Postdoc Fellow in the Department of Social Medicine, Population and Public Health at UCR, trained as a medical sociologist and also a public health person. He studies how social factors such as income, education, race, ethnicity, and sexual orientation influence health behaviors and health outcomes. We are delighted to have you all here today. That was quite a mouthful, and I wonder whether, again, I would have liked to sort of go around and have each of you sort of just say a word or two. Maybe why don't we do that before I start the questions? But would you like to say a word about your background or something I may have missed in your introduction? Whitney, why don't we start with you?
Well, thank you for the invitation and the introduction. You did pronounce my name correctly. So I'm excited to be here along with my colleagues in sociology and using sociological frameworks to understand some of the things that are happening right now with the pandemic. I guess if there is something that you missed in my bio, I was recently named the MacArthur Foundation Chair at UC Merced in Human Rights and International Justice. So I do need to update that.
My God, I already thought your bio was so long. Now you have made it even longer. Congratulations. Congratulations. Francisco.
Hi, thank you for the generous introduction, Anil, and so glad and honored to be here with my colleagues. It's just a tremendous amount of talent. I'd like to use my time to just say that I'm hopeful that a change in administration at the federal level means that we're in a much stronger position as a nation to address the pandemic. And I look forward to talking about what I think is an extremely important but under positioned set of expertise in the nation's response to COVID-19. And that's specifically that we've got a tremendous amount of knowledge and talent that has come to develop about COVID-19. Remember, we didn't know anything about this in February and March. And what I would like to see more is complementary and integral social science knowledge how we respond, because I think it's about more than just developing the vaccine. It's about how behavioral scientists can help inform strategies to address the real need around not just the awareness of COVID-19, but also what kinds of steps should we take to help with COVID-19 vaccination implementation and deployment, et cetera.
Yeah, no, that's a very important point. I was listening to an NPR story this morning, and someone emphasized this. It said that it's not vaccines, but vaccinations that will make a difference. We only have the vaccine so far. We don't have the vaccinations. Joseph?
Thank you. Yeah, your introduction was fine. I'm similarly just excited to be a part of this and to hear what everyone has to say. I think the two big picture things that are coming through to me, one would be the degree to which the pressure put on our society by this particular crisis just illuminates so many other problems and challenges we have within our society. And I think you just see those playing out when subjected to the pressure of trying to cope with this very real challenge. And certainly that's what we see in schools.
Yeah, absolutely. Sometimes I still have to pinch myself to recognize that this is all too real. It's not just a nightmare. It is happening. When this is beyond our wildest imaginations. We never thought we would ever in this country. Andrea.
Sure. I guess one thing I'd like to mention is I'm currently working on some projects that are looking at encouraging vaccination within the LGBTQ community locally in Riverside. And that's something that I'm sort of going to be drawing on today in my examples of how COVID has affected the community. But also thank you so much for inviting me to sit on this panel today. It is a pleasure to be here.
Great, thank you. We look forward to. And last but not least, our very own Richard Cartiano. You're muted.
There we go. I think don't forget Edward too.
Oh, I missed Edward. Yeah. Okay. Sorry. Why don't we do Edward first?
Sure.
So thank you, for the invitation to be part of this panel. I'm honored to be here. I'm involved with the UC Merced Community and Labor Center. And one thing that I'll mention is that yesterday our center gave expert testimony at a Latino caucus hearing on Latinos, COVID, and work.
Right. You bring a very important sort of labor dimension to this discussion. So we're looking forward to that. And again, apologies for having skipped you there. That was inadvertent. And so then, yes, it is last but not least, Richard.
Well, first off, it's just great to be part of this panel. So I'm really glad to be here. But in the interest of time, I'm not going to add much else. Your introduction was really quite nice and generous, Anil. So thank you very much. And let's get on with the show.
Okay, great. So let me, the first question I want to have all of you address is the following. What vulnerabilities and disparities or inequities have been identified or even exacerbated by COVID? And how do these vulnerabilities or disparities vary along racial, ethnic, gender, even geographic lines? And again, feel free to answer this by bringing in your own expertise and research that you have done in this area. So let's start, so that I don't miss someone, I'll go in reverse order now, and I will start with Rich. Rich, how would you answer that question?
Well, as we see with all sorts of crises, there really is. This is the ways that the problems seep into already existing types of inequalities and exacerbate them. And so, really, in a sense, COVID has brought to life, so many different dimensions of inequality in U.S. and other societies as well, as we're starting to see. Kind of building a bit, because I don't want to hog the mic here, and we could get into some sort of specifics with this, but just to sort of give a hat tip to sort of an earlier comment that Francisco made. I think this really is the time for us. We've been focusing so much on focusing on the virus and sort of its propagation from a very infectious disease model kind of perspective. And with that, we sort of kind of work backwards in terms of illuminating. We've seen on the news illuminations around racial ethnic disparities, other sorts of vulnerable populations, which is, in a way, I guess as a sociologist, it's exciting to see attention being actually paid to these issues that we usually don't see get as much sort of public sort of attention. But at the same time, so many other disparities that have emerged in other dimensions of life, related to work, related to wealth, to housing, and in general, and just to risk exposure overall, that really I think have gotten much less attention. And I'm really again have tip to Francisco for saying this, that I really hope that going forward we have to think, I think, more from a social science kind of a research agenda on really to see what those impacts might be.
Thank you so much, Rich. And again, Rich has been a model panelist in the sense that I forgot to mention that in the interest of time, and because we have 4 questions to go through, if you could keep your responses to 2 to 3 minutes max on each question, that would be appreciated. So thank you, Rich. Andrea, what about, are there any specific vulnerabilities that you think this crisis is exposed, and what dimension of these vulnerabilities or disparities would you focus on? Geographic, rural, urban, racial, socioeconomic?
Yeah, so COVID has had a significant impact on the lesbian, gay, bisexual, transgender, and queer or LGBTQ community. I think that this has really been overlooked in a lot of the research. So for one, housing situations make many LGBTQ people, and particularly LGBTQ youth, especially vulnerable at this time. So this is a group that even in pre-COVID times already faced extremely high rates of homelessness, making it difficult to physically distance and practice safe hygiene to prevent exposure to the coronavirus. And for LGBTQ youth still living at home, or those who've been forced back into their homes of origin due to job layoffs during the pandemic, shelter-in-place orders mean it's more time indoors and surrounded by family members who may not always be supportive of their sexual orientation or gender identity. And this can pose risk for increased exposure to violence and abuse. Another key vulnerability for this population stems from underlying mental and physical health conditions. So LGBTQ populations face high rates of mental health issues, including anxiety and depression. And the pandemic has caused many regular mental health care services to be disrupted or moved online, where they're not always accessible due to barriers to participation posed both by technology access, but also due to fear of disclosing LGBTQ status to other people that might be living in the home or listening in on a Zoom call. LGBTQ people also have experienced high rates of many cancers, even prior to the pandemic, and also higher rates of HIV, often in tandem with other comorbid conditions. And this means that they may be disproportionately more likely to have a weakened immune system, be vulnerable to COVID, or have experienced disruptions to their regular healthcare at this time when regular care has become scarce. We're seeing declines in HIV testing as HIV prevention organizations have had to roll back widespread community-based testing events. And this can lead to more cases of undetected HIV in the community, posing delays to treatment and disease management. Just 2 more things I'd like to mention. One, that transgender individuals seeking gender-affirming services and surgeries have also experienced delays and interruptions to essential care, as the healthcare services have had to take a backseat to prioritize COVID. And finally, social isolation, also a big issue, particularly for older LGBTQ adults. These adults are statistically more likely to live alone, to not have children, and this makes the need to distance from friends and community members particularly challenging. This is a population that already has elevated rates of depression, social isolation, and loneliness. And these have all been exacerbated by the need to avoid in-person contact with others. I'll leave it at that.
Great, thank you. And moving to Edward, what are your thoughts on this question, Edward?
Thank you, Anil. I would say that worker disadvantage has been exacerbated in the face of COVID. We had released a series of policy briefs on housing rent burden, unemployment, county level positivity rates, and lack of enforcement and health and safety standards, as well as excess debts. And so one that I'll mention right now is that Latinos. Latinos are statistically most likely to have had a higher increase in deaths since the onset of the pandemic than any other group when we look at folks under the age of 75. And we analyzed California Department of Public Health figures on deaths comparing the period between March and August of 2019 with 2020. And we found that in California, Latinos had experienced a greater increase in pandemic era deaths than any other group. there were 35.9% more deaths this year than last year for Latinos, only 6% for whites. Of particular concern were immigrant Latinos, who had experienced double the increase in death compared to native-born Latinos. This despite long-running research on the Latino epidemiological paradox, which finds that the health of immigrant Latinos is actually average, better than native-born Latinos. 14 counties had an over 50% increase in immigrant Latino deaths. Several of these had large food chain industries. Kings County experienced an over 450% increase in immigrant Latinos deaths. So this suggests to us greater factors driving COVID-19 era deaths than underlying health disparities. Some of these factors I'll mention later are rural geography or work in low-wage essential work and food chain occupations.
Great. Thank you. Thank you, Edward. Very sort of pertinent and relevant to today's discussion. And even within the labor movement, I guess there are so many distinctions, different kinds of labor have been impacted by COVID. Joe, what are your thoughts on this, please?
Sure, happy to jump in. And Anil, I don't know if you've seen in the chat, but sometimes it's hard to hear what you're saying. There's an echo or it breaks up. So I don't know, but just
okay.
So folks know, just because we want to hear what you're saying. But I'll jump in to say, what's happening with schools parallels what a lot of folks are talking about. Obviously, learning online is not proving to be as effective in general as learning in schools. And for a lot of kids, it creates a lot of problems, as well as problems that spill over into the family. But the nature of the other inequalities that exist in our society greatly exacerbate the inequality in terms of the negative impacts. And these just take many forms. So schools that are better financed have been far more able to equip their schools and equip their students with the technologies and supports they need to succeed. In addition, of course, you have factors, technology, which we haven't talked too much about yet, but obviously is inequitably distributed in our society, especially things like laptops and good Wi-Fi. And so while I think pretty much all public school systems have done a decent job of distributing things like Chromebooks to kids, the Wi-Fi connections are quite unequal. And in general, houses are smaller or living units are smaller. So kids have a harder time having a private or quiet place to participate. Families' ability to give support to students when they're struggling in class are not equitably distributed because some families, the parents have more education and are better positioned to provide support, or the parents of better, more socioeconomically well-off families tend to have parents or guardians working at home. They can provide ongoing support in ways that can't happen when your parent has to go, as an essential worker and has to go out of the home to work. So a variety of factors, and those are just a few of them. Obviously, higher COVID rates in urban centers and among certain groups put added stress, and those are just not at all equitably distributed. Even school openings are inequitably distributed, so that white, smaller school districts and more financially well-off school districts were all much more likely to be open for some of the time during COVID. There's a good bit of debate on the question of whether or not there is significant spread due to schooling. And I think that's both a technical, but also very much a political issue that gets also very wrapped up in the ways in which union structures interact with cities around this. So there are just many, many factors that are all adding to the challenges in general that those of lower socioeconomic status, people of color, and people in large urban centers are dealing with respect to COVID.
Thank you, Joe. I hope you can hear this clearly. I tried to reset my mic during the
while Joe was talking, but do let me know if you have difficulty hearing me. Francisco? Francisco?
I hear you a little bit better, Anil. So I think whatever you did may have helped. I don't have too much more to add. I am especially keen and attentive to some of the disparities that highlight how hard hit the Latino community has experienced COVID-19. One additional point that I will add is that I'm really taken and attentive to the observations that COVID-19 is exacerbating existing inequalities. And so we should keep in mind that while the economic downturn that is associated with our response to COVID-19 was major, and we're still trying to understand the impact from that, it comes on the heels of another economic recession that wasn't too far long ago. It was just a decade ago that we were starting to see how much of an impact to Black communities and Latino communities that housing-based economic downturn had, and it was enormous. And we still haven't fully recovered from that. And so the layers of economic downturn and impact and all of the other structural issues that are connected to it really make this a cumulative kind of impact that is difficult to disentangle, but undoubtedly high impact.
Okay, thank you. And Whitney, you have the last word on this.
Yes, thank you. And when you first asked the question, you were asking what vulnerabilities, disparities, and inequities have been identified that have been exacerbated in the pandemic. And I would say that every single vulnerability or disparity or inequity that we know to be true is only exacerbated and heightened. So whether it be your gender identity, sexuality, your immigrant status, and for sure racial and ethnic identity, we do see disparities across these lines only growing over time within the pandemic. So I think I checked today, and I think the latest numbers suggest that over 250,000 Americans have died, and California falls only behind Texas. And so we have been hard hit in California. But that death rate is not equally distributed, especially when it comes to race and ethnicity. And so a recent report suggests that 1 in every about 900 Black Americans has died because of COVID-19. So that's immense. And now the mortality rate for Black Americans, Indigenous Americans that we have data for, Latinx and Pacific Islanders are all about 3 times higher the rate of white Americans, even adjusting for age. And so we can get into, I think the next question is what are the explanations for these disparities? But I guess for this question, I think when I am focusing on race and ethnic disparities in COVID-19, I would just like to highlight that it's not about racial differences between those groups. We have dispelled any of those myths about race being biologically real. We really have to point to racism as the culprit and other sort of outstanding systems of oppression that means that these inequities have existed and they continue to exist, and they've only been heightened in the face of the pandemic.
Okay, thank you, Whitney. And that is a good segue into the second question, which Whitney already reviewed to some extent. And that is, are there structural factors that have allowed these vulnerabilities to persist or even widen? Basically, what are the reasons, social or structural, that these inequities and vulnerabilities have perhaps exacerbated? So let's start with Whitney, since you can sort of continue with your train of thought since you were approaching this question anyway.
Okay, thank you. And for some reason, you started asking the question and then it faded. So I will just try to rephrase the question from the notes we got in the email. Are there structural factors that have allowed these vulnerabilities, disparities, inequities to persist or even widen? And so as I mentioned, I'm thinking a lot about racism as a system and really thinking through Ruth Wilson Gilmore's definition of racism, I think is helpful the state-sanctioned and or extra-legal production and exploitation of group-differentiated vulnerability to premature death. So that's what she defines as racism in and of itself, thinking through systemic racism. And when I'm thinking about that definition, I always highlight exploitation, because I think racism in this way, if we're looking at structural racism, it's often important to look at the ways that both a racist system coexists alongside a capitalist system. And so that's I wrote an article recently about racial capitalism and shaping COVID-19 health inequities, and just thinking about the ways, yes, both racism upholds capitalism and capitalism upholds racism, because capitalism is based on the exploitation of groups we have deemed to be expendable and exploitable. And so, for instance, racial and ethnic minorities are more likely to be positioned in low-wage works that don't have protections, essential workers that are essential for the labor that they're producing, but not really their sort of human value. We have seen that, as Ed was talking about, even in the Valley, whether they're working in meat production plants or in the fields. We've also seen that in people who are checking us out at the counters or doing DoorDash, more likely to be people of color, people who are working as CNAs who don't have protection, cleaning the hospitals, that we have seen, again, that these groups are deemed essential to sort of our day-to-day and moving forward, but not essential to providing protections for them. So when I'm thinking about, yes, a structural factor, I think racial capitalism gives us a language to think through. And this is rooted in a Black radical tradition, Cedric Robinson, thinking about how, to quote, the development, organization, and expansion of a capitalist society pursues essentially racial directions. And so there's a lot of different mechanisms, and I can talk through more in the Q&A. I think occupational status for sure is one, but we could also name racial residential segregation and thinking about which places are considered hotspots, who's sort of left behind to deal with the ramifications of COVID-19, who's restricted to close spaces. There's been reports that cities that have, or areas, communities that have higher population of Black and brown residents experience longer wait times even to get tested for COVID-19. Issues related to homelessness for sure. And also medical bias. There is racial medical bias in the healthcare system. And so that interferes with the health access that individuals have. And there have been reports of people of color being more likely, Black Americans specifically, being more likely to be turned away when they go to receive help for COVID-19, dismissing their symptoms, and then have gone home to die, essentially. So I think there's there are multiple mechanisms we can think about when we're thinking about systemic racism and racial capitalism, but that is definitely what I would name as being one of the biggest culprits in creating these disparities.
Thank you, Whitney. Francisco, could you sort of take a crack at this question about structural factors that have allowed these disparities to persist or widen? I think you are muted yet. You are still muted.
The additional observation I would share, given that we're still in a situation where the election results haven't been certified, but we just came out of a major election, and I like to think about elections in terms of power, and one of the sort of structural factors that I think is going to be playing into how the COVID response that we expect from the Biden administration, as well as subnational leaders in response to the Biden administration, will be where are the channels of power and communication most open for these particular communities that have the most vulnerabilities, so that they can express there is a dire need. Not to say that we should ignore any particular community, but the Black Lives Matter movement, for example, uses the power of this imagery of a building on fire in a block to call attention to the special needs that community resources should be channeled and directed towards that particular fire, which isn't to say that other buildings aren't beautiful or other buildings don't maybe need some upgrading, but that there's a very acute need in this particular building. And so, you know, in terms of like structural factors, one of the things that we'll have to keep in mind is that there is a whole lot of change that came from the election, but there's a whole lot of non-change. That is to say that folks who were in power prior to November 3rd, there's a lot of them who remain in power, and their hands are on the levers that control how governments respond. And so that will be crucial moving forward.
Thanks, Francisco. And Joseph?
Yeah, I don't know that I have much to add from what others have said, because I think the structural dynamics play out in education in very related ways. There's a somewhat obvious and technical need to provide supports to schools to be able to better support young people. And there was not, there was not a political the political decisions at the federal level not to provide monies, either by giving them to states which were overly stressed or by giving them directly to enable schools to prepare. I mean, and so there's, there's just not that, there's on some level just not that much to say other than there's been a massive neglect of people in need. Certainly many things we didn't know, but plenty we knew that was not rocket science to respond to in terms of how to better support young people. And the decision was made not to do it. And so the communities that had other places to pull resources in, or the families that had other resources to pull in, did that. And the people who didn't have access to those resources are suffering. And their kids are going to suffer in long-term ways because of what's happened.
Yeah, no, that's so true. Edward, what are your thoughts on these structural factors, reasons, causes for vulnerabilities and disparities to perhaps even widen or at least persist?
Yes. So in terms of structural factors, one major structural factor that has allowed vulnerabilities to widen under COVID-19 is a lack of public agency enforcement around workplace health and safety non-compliance. Whitney had mentioned racial capitalism earlier. Cedric Robinson's work on how massive unequal forms of development create a difference and dehumanize disadvantaged people. I'd point out that agricultural and meatpacking workers in particular have a uniquely disadvantaged profile. Our analysis of American Community Survey data suggests that even among those who don't live in agricultural labor camps, agricultural workers and meatpacking workers have high rates of being immigrant. Like ag workers are 80% immigrant, 70% non-citizen. They earn on average less than $20,000 a year. And that workers in meatpacking and ag have long records of these industries have long records of disparities in workplace health and safety compliance. Because the owners don't treat the workers like they're people. And because as a public, we fail to make adequate enforcement of workplace health and safety a priority. Our August 2020 brief found large geographic disparities in pre-COVID meatpacking health and safety compliance, particularly in the Valley. In the Valley, the Valley has half of the state's meatpacking workers, but nearly 2 out of every 3 of the state's inspections related to accidents, complaints, or whistleblower-related investigations. In meatpacking between 2015 and 2020, though, we also had among the lowest rate of violations in the state. So very few violations, little enforcement, and continuously high levels of accidents, complaints, and whistleblower-related investigations. And we see this now in the COVID era that that non-compliance has seeded some of the state's largest outbreaks in agriculture and meatpacking. I mentioned Kings County-based Central Valley Meat Company earlier, but another case is Foster Farms Livingston. In April, Merced County Department of Public Health was first notified of multiple COVID-19 cases of Foster Farms. In June, it was declared an outbreak. In July, the county found that there were 2 deaths and a 40% positivity rate, which was 8 times higher than the surrounding county. It was not until August that Cal OSHA, right, the agency that's tasked with ensuring worker health and safety, conducted its first site visit. It took weeks more to find employer noncompliance. By then, there were nearly 400 positive cases, 8 worker deaths. They were ordered to shut down, and they still didn't shut down because there were concerns about the chickens, the lives of the chickens at the plant. Finally, when they were shut down, foster farms began to comply with the orders. But it took a span of months for them to get to that point. And even this discussion of chickens, when they weren't so concerned about the workers' lives, and all for poultry that's being shipped out to China. And so this is an example of how we have failed workers and we need better enforcement and interagency coordination.
Thank you, Edward. And then moving on to Andrea, your thoughts on this?
Yeah, so unfortunately, we do not have great data on the number of cases or how elevated disparities have become in terms of COVID among the LGBTQ population, because we're not collecting this data in the same way that we are collecting racial ethnic data, right, when people go to get tested. So I can speak more to sort of generalities of sort of the structural forces that might be at play here. So prejudice, discrimination, marginalization, and stigma contribute to many of the inequalities faced by the LGBT community pre-pandemic and during the pandemic, right? These factors contribute to the high rates of LGBTQ homelessness, as youth in particular are pushed out of homes by non-supportive families. Similarly, employers may discriminate against hiring LGBTQ employees, which may necessitate some turning to unsafe work, such as sex work, to survive. And unstable living and working conditions, we know, make self-isolation difficult and elevate the risk of contracting COVID. Stigma and experiences of marginalization and discrimination are also major sources of anxiety and psychological distress, as well as sources of feelings of isolation for this community. These factors contribute to the critical need for ongoing and culturally sensitive mental health care and social support services for LGBTQ people during the pandemic and beyond. Providers' lack of knowledge about LGBTQ people's specific healthcare vulnerabilities, as well as their discrimination against LGBTQ patients, are also really key factors that have contributed to inequities in pre-existing health conditions, even prior to the pandemic. But these, of course, put many LGBTQ community members at elevated risk for COVID. And much of this stems from a systemic lack of LGBTQ competency training in medical education curricula. And finally, we know that both fear of being discriminated against in healthcare settings and previous negative experiences of discrimination in healthcare are barriers to healthcare access for LGBTQ populations. So this can lead to diagnoses in later and less treatable stages. We might assume that the same factors that have been documented as deterring healthcare access in pre-pandemic times for things like cancers may also lead some members of the community to avoid COVID testing or seeking treatment for possible or confirmed COVID symptoms, which of course can lead to longer-term negative health outcomes. Thanks.
Great. Thank you, Andrea. And finally, Rich.
Yeah, for me, I mean, well, I'll say yes to everything that's already been said, but I think one thing I'd like to add to this, and I guess it's personally speaking, it's the thing that that just surprised me throughout thinking back to even the early days of the pandemic, and that's the role of ideology. I mean, okay, so that might sound very, sociologists love to throw around big words like that, but really what I mean in terms of brass tacks is really where we see really and what's emerged is a very dangerous sort of marriage between sort of political ideology and already sort of, or political beliefs rather, and as well as sort of a already sort of rising sort of sentiment or culture that we sort of nationally as well as internationally in regards to an anti-science sort of worldview. And so where that's really manifested itself for the pandemic and really, you know, fundamentally bad ways are, first off, is the idea of where this plays out through structure is we see this playing out with our political leadership. Naively, I thought that at the beginning of this pandemic, I thought to myself, well, the public's now going to really understand the role of public health. And, we're in the United States, given our critical mass of scientific expertise and all other resources that we have, we can mount a response to this. This is good. And it's a national crisis. America is going to come together on this, like we did for, like we can think of, I lived in New York during 9/11 and thinking about, those sorts of things. No, we have not seen that happen. And we've seen essentially a lot of laissez-faire type political leadership that has politicized and hand-tied public health response, both at the federal level, as we see with the CDC being undermined, as well as at the and even the local level, as we see here in Riverside County, even in terms of when masks were rescinded back in April by the county supervisors. It's in a way our public health officer here was ahead of the curve. And in addition to that ideology, and also being sort of cognizant of my time here, the other thing that it's really brought to the fore is the role of health social movements. In general, that's definitely a sociologist sort of big area of study. And often we think about social movements as pursuing always these sorts of just causes. We think about movements for civil rights and other sorts of, fighting sorts of other types of injustices. In this case, though, what it's really brought to the fore, the pandemic itself, is the role of health social movements for anti-public health, in essence, for undermining it in terms of really propagating anti-science, anti-expertise to effectively undermine even the most simplest types of public health interventions. But we've seen them basically at every single stage of public health response. Tied in with that in politics is the idea that public health is generally something that government does. It's public health. It's not usually private health. And so as a result, anything that public health does by definition is essentially viewed as government action. And so for these types of movements and their political ideologies, they're very heavily centered on kind of a libertarian, often very, we can say it even from observations and from my study of it lately, much more sort of a fringe sort of right-wing kind of element of it, not sort of what we might consider sort of what we might see of sort of a center-right kind of republicanism of what we've seen in the past. We certainly see efforts that have been quite effective in undermining public health response to the pandemic. It's at really every stage, be it from shelter in place to masks, to testing, to now even what we're going to be, and I'll get into this. I guess I'll stop now because I can talk about it for the next question. But for vaccines, and what will likely be coming forward with that as well.
Actually, I think the points you raise are so important. It's all of us had thought that people will take public health more seriously now, and it's so disappointing that actually many elements in the population and policy have actually dug in their heels and gone anti-science even more strongly than before. Since you are sort of talking about this, why don't you just continue on, and maybe you will take the first crack at the third question, which is on policies. What can you sort of talk a little bit about steps and policies that are currently being implemented that try to address these inequalities, and maybe there aren't enough policies that are being implemented right now? Because we'll come to your policy recommendations and what you would like to see done next. But for now, would you talk about anything which is a little inspiring or hopeful to you about the way these disparities are being currently addressed?
Absolutely, yeah. Anil, I'm so glad you asked. So, and rather timely, I think, for this panel as well. So the state of California has released a draft plan in terms of its COVID vaccine dissemination strategy and policy with it. It's been highlighted before. We've seen certainly vast disparities in along racial ethnic lines, or people also across age, across home, other sorts of vulnerable populations as well. What I am heartened to see now, it's a policy document. It's written at sort of we could say a bit of like a 5,000 sort of foot view, and is general at this point. But I was heartened to see in reviewing it a very deep concern. Well, first and foremost for data and evidence, which is always refreshing, and I applaud the state for taking that approach, but very much a concern for equitable distribution. And in what that means in turn is using data, leveraging evidence that we have in order to best assess throughout the state, because when you think about geographic, just the geography of demographic compositions throughout as huge a state as California is, how important that kind of data kind of approach to identifying vulnerable groups and to being able to address where exactly we need to be prioritizing vaccine distribution across different counties and even within counties, and thinking through that. Not only just, I mean, and from the way that the report lays it out, I'm impressed that it's not just sort of boilerplate, sort of a thing to just sound nice, and that's going to be an approach. But what's also added into it, which is great to see, is also a concern about actually how that might be implemented, and along the way how that might be tweaked and evaluated as we start to roll out the plans for, realistically, the vaccine is going to be more scarce at the beginning as we start to really roll out supply, roll out capacity to be able to distribute it and get people vaccinated. So to me, that's been sort of the bright spot, at least for the past week, that I've been thinking about.
Great. Whitney, your thoughts on what is what are sort of policies or steps that have been taken or are being taken to address these disparities?
Yeah, I really liked what was just shared by Richard. So also one of the big picture arguments, I guess, as a sociologist, if I'm identifying an unequal society that's built up or held up through oppressive symptoms, the most comprehensive way we can address this is to rework those systems and address inequality at the broad scale level. So that, all of us are going to keep echoing that as much as we can. But I think in the interim, there are some like smaller steps that are aligned with that idea that maybe allow us to grasp onto a little bit more. So some of those things, I'm going to echo our colleague at UCLA, Chandra Ford, who put forth 8 specific health equity interventions that really centers those communities that are most hit. So for one, starting with finding out what the needs are of the marginalized communities and working in line with them. If we're creating some sort of health policy intervention like wash your hands, we need to also question what sort of structural barriers would get in the way of doing those positive health behaviors. So making sure that not only are we trying to speak up health behaviors, but how we can get more people access to those. So making sure everyone has access to clean water. Also thinking about other risks and vulnerabilities, including homelessness. There's been a lot of campaigns that I've really liked about stopping evictions in the pandemic. Allocating resources in our budgets, community health budgets, for prevention strategies, intervention strategies that can just allow people to continue to live day to day, more stimulus packages and money. Also figuring out childcare access. So a lot of women are now out of the workforce, and that, what sort of structural barriers are in place there. So really, I think I would say highlighting those people who have been hardest hit across a variety of dimensions, and figuring out specific policies that would allow for more equitable outcomes and allow them to do the things that they need to do to be healthy in this moment.
Thank you, Whitney. Edward, your thoughts on this?
Thank you. In terms of steps taken or policies that are being implemented to address these vulnerabilities and disparities and inequities, I think first, we'd echo the point that has been made several times today about the need for a shift in public discourse on COVID-19 policy. In particular, the need for a greater safety net, especially among those persons furthest on the margins. Many of the efforts for mitigating the COVID-19 crisis have focused on individual level behavior, such as wearing masks, avoiding crowds, and social distancing. And many state efforts have focused on education around these behaviors. But research that our center has conducted has found no evidence that Latinos do not follow individual level public health mandates, like wearing masks, avoiding crowds, or social distancing. There's no difference between different racial groups when we surveyed 2,400 registered voters in the city of Fresno. And in addition to that, we found that more than half of households in communities of color, Latino, Black, Asian, had experienced income loss in the pandemic. Researchers affiliated with our centers, such as Maria Elena de Trinidad Young, have done research on rural immigrant Latinos and found that they experience financial insecurity as well, and that they've worked in environments with unsafe practices, and that they did not speak out due to fear of retaliation. This is something we've heard again and again and again. In terms of policies to address workplace health and safety, we've been in discussion with the Safety Net for All, a coalition of 125 of the state's largest immigrant and worker rights organizations. And there were particular measures such as creating disaster relief for immigrants that the state, took a first step towards, but did not create in a way that, they created a fund of $75 million. But, this was only, going to give 150,000 people like $500 each, not nearly enough for the need for those persons that had lost jobs. And as long as people are afraid of losing their jobs and they aren't protected and coming forward and making reports about workplace health and safety non-compliance, we're going to continue seeing these same egregious practices that we see in some low-wage essential occupations. And the last thing I'll mention is today was a hearing for the emergency temporary for a COVID-19 emergency temporary standard, which is again an important step in the right direction to create workplace health and safety standards. But then enforcement is the big issue, because again, with what we saw with meat packing before the COVID pandemic was unequal enforcement, and even so, in those places that were fined several times for non-compliance before COVID, now they're the sites of big outbreaks. And so we need not only enforcement but for it to be regionally equitable.
Okay, thanks, Edward. Moving on to Andrea, your thoughts on these steps being taken or policies being implemented to address the vulnerabilities or inequities.
Yeah, and so in preparation for this question, I actually spoke with representatives from a number of local community organizations serving LGBTQ populations in the Inland Empire. And so before I sort of share what they've done, I really want to give a shout out and a thank you to Jorge de los Santos and Cassandra Sejas from True Evolution, Jill Gover from the Desert AIDS Project, and Christopher Christensen from the HIV and Aging Research Project. They really helped me to inform the comments and the local initiatives that I'm going to share with you today. So first off, True Evolution is one of the Inland Empire's leading LGBTQ and HIV organizations. And they're seeing firsthand the toll that COVID is taking on their clients, many of whom were unstably housed before COVID or became newly laid off due to the pandemic and are struggling to make ends meet. Before the pandemic hit, they were already providing short-term emergency transitional housing to clients in need. However, people often faced long waits to accessing the service. So thanks to the governor's shelter-in-place order early in the pandemic, True Evolution was able to link homeless LGBTQ youth living with HIV to 21-day emergency housing in local hotels within a matter of days. And they are now working on a new project, Project Legacy. And this is going to establish longer term supporting housing services for, they're saying approximately up to 2 years. It's going to house over 50 LGBTQ youth living with HIV in Riverside, so a longer term solution. Physical distancing has also reduced the organization's ability to conduct face-to-face HIV testing, as many community testing events that previously occurred, including testing events that used to occur on UC Riverside's campus, are no longer possible. So a second initiative that will be undertaking is the provision of at-home HIV testing kits. Now that the CDC has approved these can be mailed to clients' homes, especially for clients in some of the most vulnerable communities. So this cuts out the need to access tests in person. And these HIV self-tests will be paired with linkage to support services for those that receive positive diagnoses. Also speaking with the Desert AIDS Project in Palm Springs, this group serves a predominantly older demographic of people living with HIV, many of which identify as LGBTQ. And this is a population for whom the majority did not get married or have children earlier in life, and many became estranged from their families of origin. So they often do not have younger family members that can take care of them. So in addition to facing interruptions to regular healthcare, this group faces increased risks of social isolation and loneliness due to COVID, and many have multiple comorbidities and are being told that they must self-isolate. So in response, the Desert AIDS Project has moved its behavioral health, social services, and wellness activities all online. Everything that used to be offered in person is now has an online parallel. But given older adults tend to be less comfortable interacting online, navigators have been working one-on-one with clients to facilitate telehealth visits. The organization has also secured grant funds to provide smartphones to telehealth clients who cannot otherwise afford this technology. One more initiative that they've taken to combat social isolation is that the organization has planned a number of outdoor socially distanced activities for clients where everybody will be standing in chalk circles in the parking lot. And this includes things like yoga, a silent disco that really are just aimed at getting community members out of their house, providing an opportunity for safer socially distanced interactions with peers. Thank you.
Thanks, Andrea. Moving on to Joe, what are your thoughts on this? Do you see sort of any hopeful signs that some of these vulnerabilities are being addressed?
Sure. So I'll, my focus on education, I'll focus on a few of the things schools have done. On one level, it's just been an incredible crisis and there's a lot of loss. There are some impressive things that have happened though. So certainly the distribution of technology is not something that schools would normally do or had normally done, and they very quickly mobilized to just give out fairly expensive technology to people in their homes so that they could participate. So, I think that, you can appreciate that. Certainly there was nowhere near the support there could have been from the federal government to facilitate that kind of thing, but it helped. There were also, I think, some well-meaning efforts to expand, access to Wi-Fi, which, again, in a crisis made a difference for many people. Not enough of a difference, certainly, but it helped. Another major move was the distribution of food. So for many kids, school is where they get breakfast and lunch, and much of the best nutrition they get during the day. So the fact that schools were closed created huge issues. And again, schools have mobilized to distribute and become distribution centers for food, frequently giving out food not only to kids who go there, but to families, and frequently doing it in ways that are, face-saving and supportive, and trying to be as good about it as they can. Not perfect, but certainly they established new mechanisms for being supportive through food, and that's been crucial. And then I'd say two big things about efforts to bring kids back. Probably the single group that is most adversely affected are students with disabilities. And in many districts, it's been a priority to try to get students with disabilities back to face-to-face learning as soon as possible. and prioritizing that. And the second would be elementary age kids, certainly both because there's less of a risk of transmission, but also again, because it's harder, to expect a first grader or kindergartner to do very much Zoom during the day, especially if their parent has to be at work. And so I think the policies that prioritize that group and have gone to great lengths to support elementary school kids have made a difference.
Oh, great. Hopeful signs.
Yeah.
And then moving on to Francisco. You have the last word on this particular question.
I guess so. What I would add is not any observation about specific policies. I think that some that were already listed give us a set of guidelines. I guess what I would point out is that in many cases, the casualties, and by the way, it's not just in addition to the number of people who have died, right? There is like an unknown factor about how many people will be affected by COVID-19 in the long run. We just don't know yet. We have clues, and a lot of those clues suggest that there will be long-term effects for folks who have lung damage, but there's also damage to other organs, and we just don't know how that's going to play out. But it turns out that that's going to be crucial to take into consideration as we move forward. Past COVID-19, there is likely to remain debates that we haven't resolved yet around healthcare access, for example. And we know that a lot of that is political. So from a strictly social scientific perspective, it's difficult to talk about the United States response to COVID-19, and it's more accurate to think in terms of the 50 state response to COVID-19. And there's tremendous variation. By, I think, May, I saw 3 or 4 working papers that political scientists had crafted showing evidence of COVID-19 casualties being linked to the partisanship in the governor's mansion in various states, as well as who controlled the state legislatures. So when it comes to thinking about what policies work, I would also add that we have to think about who it is that's crafting those policies. And to a point that Edward brought up earlier, the kinds of mental models that they bring to the table when they imagine what the problem is. If they imagine the problem is individual level behavior, we shouldn't be surprised when they put forward solutions that reflect that thinking and emphasize, masks, which lead us then into having conversations about the right to wear masks or not to wear masks, as opposed to a conversation that is, oriented towards there's a pandemic. We should be making policy that's informed by epidemiological knowledge, and here's what. Here's the playbook for best practices, and sort of moving forward with that.
Thanks, Francisco. And in a sense, you have already touched upon the fourth question that I was going to ask of all the panelists, which is, that are there any specific recommendations that you can offer as we move forward to cope with COVID and to address the inequities that we have talked about arising from COVID? And to some extent, you sort of started addressing many of these issues, what you would like to see done, but perhaps you can be a little bit more specific about any particular recommendations that you think would work to improve the situation.
Yeah, so broadly, I think it will be useful for us to think in terms of power, and we would be wise to recommend or at least take into consideration that whatever might work for advocates of a optimal response to address COVID-19 in California may not work in Texas, for example, because the folks that they're going to be lobbying and addressing and engaging are just coming at this from fundamentally distinct points of view. And so we should take that into consideration. And the other thing that we might take into consideration are policies that address some of the specific challenges that our panelists have been raising with respect to structural factors and vulnerabilities. Here's just one small concrete thing that we should keep in mind. And I know that the task force that President-elect Joe Biden has assembled has folks that are sensitive to these very topics. And that's that we should think about, to Richard's point earlier, we should think about how trust in science is distributed across the population, that we should engage group-specific and historically relevant narratives so that we're not scaring people away from trusting the science, and that we should also, to this earlier point that I brought up about politicians and power distribution, we should be mindful that it's not actually wise to put politicians as the public face of any kind of message campaign. We have known for some time that trust in government has been going down, and recent analyses of trust in government and institutions from a team that has been surveying the American public since as far back as March on the topic of COVID-19 reports that politicians are the least trusted individuals, and yet they are by far the folks who get the most airtime on the topic of COVID-19. So the public is consuming from these particular messengers information, and they don't trust that messenger. And by contrast, the folks who, regardless of race, so across race, across partisanship and partisan identity, across socioeconomic standing, the individuals that are trusted the most are scientists and healthcare providers. And those are the folks that we should be elevating and propping up to send these messages. And by the way, it should be something that is not just on the shoulders of Dr. Fauci, right? This should be something that is localized. We should have Inland Empire, for example, the news that spread in Riverside and San Bernardino, and the morning talk shows, the evening news shows, they should showcase and put in front our public health epidemiologists, not county officials, right? And local healthcare providers. So doctors and nurses saying, here's why it's still important to use a mask. Here's why it's important to only gather with the people you live with for Thanksgiving. It's going to be a different Thanksgiving this year, folks, but this is what we need. And to start laying the foundation for those trusted messengers to deliver updates and campaign messages about the vaccine in order to optimize how willing people are to get those vaccinations.
Great, thank you. That's, I think, very important steps to move forward. Joe, your thoughts on this?
So, yeah, I mean, I think again the broad dynamics that people have been talking about, for the whole panel, just seem to be the key. And the questions in terms of specific kinds of things, I mean, a lot of it is going to be about money. So states and localities have been hit incredibly hard and will continue to be hit hard. And a lot of the kinds of services and supports that are going to have to flow out through either intermediaries or through states are going to take money. And so, obviously there's a huge need for stimulus. There's a huge need for just federal expenditures for states that have been really hard hit. The kinds of things that might mean in the education sphere, especially to deal with the inequality of impact of COVID, would be significant increases in educational spending. So, for example, if we are able to go to in-person schooling, that there'd be schooling options, especially in places that were hard hit, that would run through the summer to try to help pull back some of the costs, in terms of learning deficits that will be enormous. But along with that, you're going to need all kinds of other supports for kids. I mean, they're going to need, once we are able to do much more, much less sheltering and much more interaction, they're going to need programming that allows them to do all of that socializing that is so essential for young people. It's essential for all of us, but you're just going to need all of those supports in amplified amounts in order to begin to address massive deficits in terms of inequality that have been created.
Yeah, and then a whole year that was basically lost.
It's yeah, and I mean, all the evidence shows, for example, in the summer that, you know, the learning loss that occurs over the summer hits poor communities much harder than it does better off communities or better off households. And so that's just going to be magnified, you know, instead of it being a 2-month summer, it's a full year.
Yeah.
The differentials that'll be created are enormous.
Thanks, Joseph. Whitney, what about your thoughts on this, on policy recommendations?
Yeah, I mean, I really like Francisco's point about just making sure we keep power at the center of these conversations when we're thinking about particular policies. I was trying to think of a few other things that maybe haven't been mentioned so far. And one thing is we also need better data on COVID-19 and who is being harmed and in what ways. So for instance, as Andrea said, we don't have great data on LGBTQ community. I've been trying to look at data that is maybe more intersectional, so within race, gender breakdowns and otherwise, and we just aren't getting a lot of data out there to really understand the magnitude of the problem for vulnerable populations. And so I think continuing to urge politicians and community health departments to disaggregate data and get that out to us would be really important as we're working towards these policy interventions. And then another sort of consideration I'm thinking about is just, especially when it comes to health and health equity, is making sure that these other, given that the pandemic exacerbates existing inequalities and inequalities in health, we need to make sure that we are being consistent in these other health problems that communities are already dealing with. So mental health is one for sure. That has been increased even in young kids because of the issues related to school, but I mean, faculty burnout is real too. So across the board, there's been ebbs and flows in terms of medicines being delivered, rises in insulin, these sorts of things. We cannot forget all of these other health problems that are already existing. We need to make sure we're being comprehensive when we're addressing the problem. And so I know I saw one of the questions in the Q&A is about Black maternal mortality complicated by COVID-19. Almost every health outcome has been complicated by COVID-19. So you see Black populations that already have extremely high rates of, for instance, maternal mortality, and then a drop off of social support. You're removing their support out of the hospitals and out of other spaces, increasing stress, and all of these things are amplified. And so I think just some of the, I guess, consideration is yes, power, and then also comprehensive health equity. What does that look like across the board as we're addressing this pandemic, but health equities that have been persistent over time as well?
Great, thank you. Rich, your thoughts, please.
Yeah, boy, I could talk for about a good hour about this stuff, but I'm gonna try to keep it. I'll be kind and I'll keep it short. But you know, first and foremost, I think we really need to be thinking about funding for local public health. At pre-pandemic, public health agencies had already been strained due to underfunding and being under-resourced. They've certainly been strained now during the pandemic. And let's just imagine hypothetically that a vaccine were approved and was magically distributed to everybody tomorrow. In the wake of all the things that we've talked about during this session, things that all the problems that have emerged or been exacerbated, they will now have to deal with those as well in the wake of this, which at current resources is not acceptable. So we really need to be thinking about from federal. It's really mostly going to be federal funding and really sort of a federal sort of commitment to this being distributed to states and then on down to counties and local agencies. We also need to be thinking about sort of, I guess you could say, reinvigorating the reputation and the independence and the expertise of the Centers for Disease Control, which has really been hand-tied and pushed to the and sidelined throughout this pandemic. Even though it was a world-renowned agency, it still is, and we need to be re-recognizing that and giving it the scientific independence that it should have. And not be as prone to political meddling as what we've seen in the past few months. And then tied to this, and I think this really does have implications for thinking about inequities, health inequities and other inequities, both within the United States, as well as just our impact upon other nations as well. And that's rejoining the WHO, the World Health Organization. Being a member of that, I mean, if anything, the pandemic has shown to us that no country is an island unto themselves, that we are all interdependent, and that a pathogen or a virus can travel within hours and set off, everything that we've seen. So it's going to be essential for us to be part of that type of alliance in terms of sharing information. It's important for the United States in knowing when there's going to be particular sorts of threats, as well as for us to be, and I think it's an obligation for our nation as a world leader and as a citizen to be able to share that information with other nations that could be potentially quite heavily hit, as we've seen with, say, for example, Italy, or we might think of lower socioeconomic countries too, that have less of a health infrastructure, and for which situations like this can just ravage a country potentially. So we need to be thinking about those three factors. I think would be key.
Great, thank you, Edward. You are muted. Oh,
yeah, thank you. As far as recommendations for moving forward to address the realities of the pandemic and these inequities, so one recommendation we had made in our July brief, Hidden Threat, was to report COVID-19 cases by occupation and by industry. Since then, AB 685 has passed the state legislature, and employer reporting of COVID cases by occupation and industry will begin on January 1st. But one recommendation we would make is that the data needs to be accessible so that researchers can track the dynamics of the spread of the virus in real time. Sometimes, there's these unfunded mandates where state agencies are made to do things, and on a shoestring budget, the data might be placed on a website that the public may not be able to access it, or it may be in some form that's very difficult to work with. If it's in some database where you have to cut and paste things a lot, that's not the same thing as having it in an Excel spreadsheet that people can analyze easily. A second recommendation would be that education efforts, in addition to emphasizing the importance of mask wearing and avoiding crowds and social distancing, needs to focus on workplace-related behavior, such as workplace health and safety education, worker rights trainings, and the use of compliance-related mechanisms like filing a complaint through OSHA. One thing I hadn't mentioned earlier was that complaints about health and safety non-compliance are up in some industries this year, such as those in professional occupations, but they are actually down in some cases, like with agriculture. In agriculture, there were fewer workers that reported workplace health and safety non-compliance between February 1st and November 15th this year, compared with the previous year. Which is surprising because there's a global health pandemic, as well as catastrophic wildfire season. So for there to have been fewer complaints means that people are not coming forward. And it emphasizes the importance of these trainings around workplace health and safety, as well as know your rights training, so that workers know how they can come forward about things. And third and lastly, I would say greater enforcement around workplace health and safety standards, as well as interagency collaboration.
great, thank you. And last but not least, Andrea, you have the last word on this, and in fact, the last word in the presentations. Then we are moving to Q&A after this. Great,
thank you. So I'm going to echo exactly what Whitney and Edward started off by saying: data, data, data. We absolutely need better documentation of the impact that COVID is having on different communities, including LGBTQ populations. Most of the data that is out there is very small local studies. We need some national data, I think, so that we can speak more generally about what is going on for LGBTQ populations across the United States. So some other key things I think to address for this community, as I alluded to earlier, right? The virtual world is not always a safe way of maintaining connections, even though it may be safe in terms of avoiding COVID. Participation in virtual spaces is not always possible or safe for everyone, right? Not only may some LGBTQ people lack access to virtual spaces, but for some it may be unsafe to do so for fear of disclosing their sexual orientation, gender identity, or HIV status to the people that they're living with. So we need to be cognizant of those needing support that may be excluded from participation in virtual healthcare and social support initiatives during the pandemic. Something that has repeatedly come up in some of the recent research projects that I've been working on with this community is previous experiences of discrimination in healthcare and a lack of knowledge about LGBTQ health among providers. Right? Even before the pandemic, there's been an urgent need to integrate more LGBTQ competency training into medical education. And this need is further exacerbated at a time when we're seeing increasing diagnoses of COVID requiring immediate medical attention and possibly long-term follow-up care. And so finally, my last recommendation, I really would like to emphasize the key to addressing the inequities experienced by LGBTQ individuals, as well as inequities experienced by other specific groups across the life course, both during the pandemic and beyond. Key to this is going to be consulting with members of the community, as well as the organizations that serve them, to identify their most pressing concerns and develop policies and interventions that address their needs in a culturally competent and culturally sensitive way. Health disparities for LGBTQ populations are not new. So any means of addressing them should focus on the root causes and focus on identifying long-term solutions that can have a lasting impact beyond the pandemic. Thank you.
Great. So that sort of concludes the presentations and thoughts of the panelists on these guided questions. And now we are opening up the floor to questions from the audience, and we already have a few questions in the Q&A box. Again, I had mentioned this earlier in case you've logged in later and you didn't hear me say this. Please don't pose your questions in the chat box, but there is a separate Q&A, question and answer box down in the bottom panel of your Zoom window that you should click on and submit your question. So this question from Arlette Flores Aparacio for Whitney. How would you advise the community of color and people of color to talk with one another to help understand the severity of the pandemic? For example, the Latinx community is rooted with family and family culture, yet we are being advised to stay away from non-household family members.
Yeah, that's a great question, and I will take a stab at it, and then maybe others want to jump in. I think one recommendation I would have is just to make sure that these recommendations that are coming, top down, resonate with communities in a way that makes sense. So, for instance, there was a lot of conversations about creating pods when childcare fell through and schooling. And so you would make an agreement with your pod. These are our guidelines and we see each other and we support each other in this way. And that was really helpful for especially affluent families that were struggling. But we could do pods among our family too, as long as we talk to one another about what the guidelines are and best ways to be protective and supportive. And so, I think sometimes it's just a matter of communicating in a way that makes sense. I know that early on there was a lot of health PSAs that weren't being translated. And so that's an easy fix, the ones that should have been addressed, right? But people weren't even having information about COVID or the data or who it impacts in a language that they could read. So those are just two things that are sort of top of mind. But even if you're not a data person, if you show somebody maybe just a curve of the rates, how they're rising, how particular communities of color are being harmed, I think that just starting the conversation that this is a real pandemic crisis that we're in and we're being impacted, then maybe it might make sense for our family members and our communities.
Mm-hmm. Great. Would anyone else like to chime in on this issue? Okay, if not, then let's move on to another question that's been posed, and that is by Iqbal Pitalwala. And he asks, one extraordinary but predicted consequence of COVID is the higher rate of domestic violence we are seeing now. Have any of the panelists studied this issue? If so, could you please share your findings with us? And even if you haven't really studied the issue, but have thoughts on the subject, maybe you could answer Iqbal's question.
I'd be happy to chime in.
Great, Rich.
Yeah, I mean the sad tragedy of when you're faced with such a an overwhelming public health crisis like this that's forced the response that we've had to take is so many other unintended consequences related to health, and and well, we've talked about the social consequences, but we can also think about the other health risks that it's magnified. Domestic violence certainly being one of them. Avoiding necessary care, either regular care or other sorts of more pressing health issues that need to be addressed, of course. Even concern about vaccinations for other diseases, things related to the flu shot and measles, for example. And certainly a lot of concerns have been brought up about as well as suicide and other sorts of mental health issues. So where I'm going with this is not something that I've directly sort of studied, but I would like to talk about it in terms of framing of issue framing, because I think it's very important. What I found very disconcerting about this is domestic abuse is a very serious public health problem. It's a broader sort of social problem, and as are suicide, as are many other issues that have been sort of brought up in the public discourse to date. Unfortunately, the way that they have been used, I would contend that these have been used in a rather sort of disingenuous sort of way. These health issues. I find it really sort of concerning and a bit tragic when these issues have really been used as sort of efforts to try to push for opening policies that are not necessarily appropriate and that can be creating more public health risks. It's not to say that we should not be identifying these problems. It's not to say that these are not problems in and of themselves, but the people who've been sort of really been focusing very heavily on those issues, as important as they are and that we should be giving attention to, have really been focusing on them as sort of in a sense, a sort of Trojan horse sort of argument in a very disingenuous way to try to push for sort of pure up opening policies or ways to sort of dismiss the severity of the pandemic. So my argument kind of just comes to this as, where were these individuals arguing for the funding to address domestic abuse before COVID, or to address substance use, or to address suicide? Mental health has for a long time been a sort of an under-recognized American epidemic. And so but yet we see in terms of mental health funding, mental health services, we see less sort of attention and less resources being given to that. So my argument would be, if you're going to, this is not addressed to Iqbal at all. I know he answered the question in a most sort of sincere way, and I thank him for raising that. And I completely agree. As somebody many years ago, I actually, domestic abuse was something that I studied as one of my areas. But to the way to which we think about agenda setting and the way we've seen that the pandemic has sort of been politicized, we unfortunately have seen these sorts of other public health issues been sort of brought up in very sorts of disingenuous sorts of ways to really try to push for unsound public health response policies.
Yeah, that is unfortunate, but you are. This is so true. It's also, I think, one of the things you mentioned casually was that, but this is going to be extremely important, I think, as we go forward. All the healthcare that's sort of not being attended to because of COVID, we are probably not going to see the full ramifications of not doing proper, the other vaccinations, not going to the dentist for a whole year, not getting your, a blood test done or follow up on your chronic health issues. We are probably going to see the adverse effects of all of these missed appointments, so to speak, a year later or several years later. So the full impact of COVID, we are probably going to feel it in the years to come. We have one more question. Oh, another one has popped in. There is a question from someone who wants to remain anonymous, and that is, what steps can we take as a community to reduce Black maternal mortality that has been exacerbated by COVID-19? It's not directed to anyone in particular, so if anyone would like to take a stab at this, Black maternal mortality that has gotten worse because of COVID, what can we do as a community to bring it back under control? Any takers?
I'll chime in with one thought. This is not a partisan endorsement. However, I will say that there is a very large amount of evidence that says when Democrats are elected to office, Black mortality rates are lower. And so one very concrete thing to do to reduce Black maternal mortality that inevitably is likely to be complicated by COVID-19 is to elect more Democrats.
Yes.
I'll add to that. Yeah, I didn't know that statistic or that fact, but I do know that there have been community-based organizations who have been advocating to address the Black maternal health mortality gap and with legislation. So that's really exciting, thinking about both community activism on the ground and how they're trying to enact legislation to be more productive. But I think the community aspect is really interesting, and something that I have has given me hope in this moment is the rise in sort of mutual aid collectives across the board, raising money, for instance, for communities that maybe were left out of the stimulus package, or just sort of doing more community-based wraparound. And I think in this moment, this would be really important for somebody who's pregnant and those groups who have these high risks, is just making sure that they do have social support, which we know is a great sort of buffer against stress and discrimination in that moment, and that can improve health outcomes. And so making sure that there are, even if it's dropping food off at the door, but there's enough like sort of infrastructure at that community level, so these groups aren't sort of left behind. So that's just one thing I wanted to add, really, because I know your question talked about the community, what the community can do. I think it's a good time for us to envision where the gaps are at the federal and local levels, and how we can step into and fill those gaps in ways that are equitable, where we have buy-in within our own communities.
Thank you. Another question here, a question by Victoria Estrada on, and this is a broad question. What do you think it will take for most people in this country to feel confident enough about receiving a vaccine when it is released? And she mentions that, because this issue has been politicized, lots of people who otherwise might have gotten vaccinated are probably not going to get vaccinated. And so what can policy do to get these people to back in the fold and consider vaccination? Andrea or Rich, do you want to take a crack at this question?
I'll take a lead in so that Rich can jump in after. I don't know that I have the answer to this question. However, I have been doing research around adults in the communities on response to various other vaccines. And something that is repeatedly coming up is the fear that getting vaccinated is going to potentially cause birth defects or threaten people's ability to have children in the future. This is what I'm seeing with adults aged 27 to 45. So, these are real concerns. Establishing safety and efficacy and sort of disseminating knowledge around safety and efficacy in a way that resonates with community members, that's delivered by people who community members trust, I think it's going to be really, really key in this. And then also, of course, there's the need to dispel sort of or misinformation about the vaccine, which is already sort of proliferating on the internet. But I will also pass this on to Rich, who may be even more of an expert on this topic.
Rich?
Well, thanks. So picking up on that, I mean, in general, we have to recognize the fact that first off, Operation Warp Speed has done a really ineffective job of communication. It's relied on this sort of this usual sort of trope that technology is always going to save us. This usual thing where we kind of look to Silicon Valley for the solutions to all of our sort of social ills. We kind of see the same thing here with pharma. It's been to be clear, it's been a tremendous success in terms of the scientific innovation of it. But at the same time, things like the name Operation Warp Speed, the politicization of it, particularly in the weeks leading up to the election, have understandably created concerns among the broader population, even people who might have been in the past much more inclined to get a regular flu shot, for example. So really, in the sense of once this starts getting once approval occur, actually it should be occurring now. There needs to be the education campaigns really need to be first and foremost. I mean, a lot of people like to think that just developing the vaccine was going to be the challenge. My argument is, and I'm not alone in saying this, is that we have a whole new set of challenges that are now going to come forward because as Anil nicely brought up at the beginning, there's vaccines and then there's vaccination, and for it to be a vaccine to be effective, it's the vaccination that we're really concerned with. So community outreach, particularly to marginalized groups, particularly ones that don't exactly have a great history of trust with the medical field, as well as just, I think it's incumbent upon the companies that have produced these vaccines to also be engaged in this. People like Albert Bourla, who is the CEO of Pfizer, appearing, right before the market opens at 8 o'clock or before 8 o'clock on a Monday, to hype his vaccine on CNBC while sharing, screen real estate with stock prices is not exactly the best way to build public trust. And, and we can think about outreach for vulnerable groups, but herd immunity is what's important here. So it's also, we got to be thinking about, maximizing uptake in order to be helping to protect the most vulnerable and the least vulnerable. Our fates are all tied together with this. And so in a way, thinking of trying to get ahead of miscommunication, the ecosystem, the months that we've had of disinformation from the anti-vaccine movement that's now morphed into the anti-COVID kind of movement is going to be essential. We're going to be needing, the best that communication experts and public health education experts, really have to bear on this. And there's got to be a political will sort of behind it. Otherwise, if you build it, it doesn't mean that everybody's going to come, as they say.
Yeah, thanks, Rich. And by the way, not only did the CEO of Pfizer hype up his vaccine on CNBC, but then when the stock price went high, he actually sold several 100,000 shares, making profits. That is a sort of a very poor way of communicating the
And
success of
if
this
I may add
vaccine.
one other anecdote to that meeting. Now, of course, CEOs, I will even be a bit understanding of saying that there's certain scheduled times that they will sell off stock. But the fact of the awareness of the timing of this and being able to adjust that was odd. But when asked actually about concerns about vaccine hesitancy, while on that show, instead of sort of being self-aware about this, or well, I won't imply motive, but I mean, you would think at least more of a demonstration of or sympathy of being aware about this. Instead, Borla pivoted to saying, well, we shouldn't be politicizing the vaccine instead of just sort of taking a self view. I mean, I find it very hard to believe that a Fortune 500 company does not have a massive sort of PR machine as part a PR department to be able to also think through these sorts of things. And so there has to be a will also from these private sector companies. As well as from the federal government, and not just throwing this now down to the CDC and state and local health departments to now have to do the education.
Thank you. So here's a question from Deirdre Rice, and she asks, absent what we are being advised in the media, what would your suggestions or advice be for us as scholars and students in what we can do to move forward? Are there do's and don'ts that you might have for a student with respect to this issue? Again, a very broad question, but someone would like to take a crack at it and advice for a student?
I'll take a stab. What really resonated to me were some points that several of the panelists brought up, including Andrea and Whitney, about the importance of asking communities that are impacted by COVID-19 what their needs are and what they would advise. I think that a very similar or an analog tradition in academic work is already well established, and it comes with a lot of tried and true methods, as well as advocates and experts, of course, really genuinely engaging with the communities that you're interested in studying, learning more about. So the do here would be do engage those communities and do foster a relationship, not just a dialogue where it's extractive, but really sit down with those folks, because I think that positions you to produce groundbreaking work and helps us avoid, because there's a long history of academic work being conducted in a way that is just, now we have hindsight and we have entire IRB and ethics classes and trainings organized around these moments where we've really done a poor job of representing the communities that we're interested in studying. So that's what I would.
Yeah. Great. I think that's a useful advice for students and aspiring scholars, certainly. One question here from Jenny Chen for Dr. Joseph Kahn. You had mentioned about the educational disparities that COVID has amplified because of the loss of summer programs and now pretty much the loss of an entire academic school year. What do you see as the long-term implications of this school year loss for student achievement amongst low-income groups?
Yeah, it's a great question, and unfortunately, I think it's one that a lot of the educational system has been so focused on coping with what's current that it's very hard to, they haven't done the planning for what the future needs to be as much as is necessary, though of course that will come. This is an unprecedented problem. So it's very hard to be too predictive of what the long-term implications are. But unfortunately, I think it's quite likely that it will be very hard for many of the kids who have been really disengaged to get engaged again. So we've got, in many systems, you might have 30 to 40% of kids who aren't showing up to these Zoom classes. And what we know about school dropouts is that, once people drop out, it is very tough to get them back. So there'll be different kinds of interventions needed in different places. Certainly, for example, at the high school level, there will be key to get people back. It will be key to have extra resources and extra supports. Certain subject areas are going to be hit harder than others. If you're supposed to learn biology one year and you don't learn so much because it's done online, but then you have chemistry the next year, that may not be as big a problem as if you were supposed to learn algebra 1, but it was taught, it was less effective class for you because of the nature of the way it was taught. Now, we don't want to flunk those kids because then they're not going to get the units they need to graduate, but we also don't necessarily want to assume they learned everything in algebra 1. So there's just an awful lot of difficult challenges that are going to hit school systems, and because it's going to hit different kids in different ways, there's just going to be a lot to try to get on top of. I do think one of the things that is true about this is it is a problem that hopefully a wide spectrum of families and citizens can recognize. And so there's also going to need to be a campaign to build support for providing the kinds of supports that are needed. If the supports can't come through the federal level, then it's going to be up to states and localities to provide them. And so again, a lot of funding for educational supports is state and local. That can happen, but you're going to have to, whether it's by floating new bonds, whether it's by levying new taxes that are temporary, whatever it is, you're going to have to build public will for that. I think that's doable, but as we've seen, even in the recent California propositions, it's not trivial or easy. So I think there's a lot of work that's important in terms of, one, creating the strategies, and two, finding the resources to provide those at the massive scale they're going to need to be provided for. And then, of course, you're hitting kids who are part of families who are part of broader ecosystems that have been devastated by all of the factors that the panel's been discussing. So all of that will be magnified.
And I think the point that you made is that we may actually see some of these impacts manifested several years later in graduation rates from high school or from middle school. And of course, many folks in education and many economists have studied the sort of correlation of early childhood education and later life outcomes.
Yeah.
And so to the extent that some of these students have lost an entire year of education early in their educational career, may ultimately manifest in many labor market and social outcomes decades later. So in some sense, so these are tragic effects, but many researchers are going to have a field day looking at the impact of this exogenous event, as people would put it.
I think that's right. I mean, the other thing to emphasize, though, we're talking about with schools, often we think about things like graduation rates and whether kids are learning content. There's also just been an enormous amount of trauma. And the trauma's hit the teachers, it's hit the families, and it's definitely hit the kids, many of whom have had no way to process it and don't have the long life experience that helps them understand what the future is going to be.
Yeah.
And so the intersection of the educational loss with the mental health issues, it would be incredibly surprising if it wasn't just an enormous impact.
Yeah, I mean, we are seeing this even in our master's students in the School of Public Policy. I mean, many of them are saying that the lack of socialization with other students, with their teachers during these past 6 months has really sort of almost caused them despair and depression. And so I think we are going to see this play out in unfortunate ways in the future. Well, I think we've sort of pretty much exhausted all the questions that had been posed in the Q&A chat box. I also see that We are pretty much just a couple of minutes away from 5 o'clock when we were scheduled to end this panel session. So I would like to sort of just take a moment to thank all of the panelists for generously spending their time with us today. And thanks to all of you in the audience who attended today's webinar. By the way, our next online event in the School of Public Policy will be tomorrow, November 20th, when we will host Dr. Derek Brinkerhoff, who's a distinguished fellow emeritus at RTI International. And you can learn more about his talk by going to our website. I hope to see you all at a future UCR School of Public Policy event. Till then, goodbye. And again, thanks very much to the panelists.
Thank you, Anil.
Thanks for being a great moderator, Anil.